Hello, welcome. Thanks for coming to this last, what was supposed to be the first, but Alice and I don't make it well. So now it's the last talk of the semester. So we're very happy to have Dr. Christian LoBue here. He's a board licensed practicing clinical neuropsychologist scientist at UT Southwestern. He's in the departments of psychiatry and neurological surgery. And he has a really program research that has several prongs to it. His research focuses on traumatic brain injury, including chronic traumatic encephalopathy, and the risk that it confers for developing neurodegenerative diseases like Alzheimer's disease, frontotemporal dementia. Another interesting focus of his research that kind of goes hand in hand is the use of neuromodulatory techniques, such as high definition transcranial direct current stimulation, as an intervention tool to slow the cognitive loss that's seen in these types of neurodegenerative disorders, which he will be speaking to us about today. That's that part of his research program. So we're very happy to have him here today. Please help me welcome Dr. LoBue.
Thank you so much. It's a pleasure to be here after all. I had to wait a couple of months after the thaw from an ice storm. And I'll be presenting some exciting findings from our pilot trials that we've done at UT Southwestern. Yes, with any talk, financial disclosures, we do receive research funding from several organizations to conduct this. So here are my disclosures. But as you know, science is a team sport. I can't do this all on my own. So listed here are the key members of the team. You'll recognize some familiar people here. Dr. John Hart, Dr. Shane Jong, who's now in Boston. But they were key members to carrying this study out. And, I had a time slide, sorry. They're key members to carrying this study out. In fact, we actually did a portion of one of the studies at UTD in Richardson. And then my research coordinator, Anna Cabrera, was responsible for delivering the interventions after a rigorous course of training to operate the equipment. So getting into Alzheimer's disease, I know you've all have heard many things about it. I'm not getting into the basics of pathophysiology, but I want you to really kind of come to mind that beyond pathophysiology of amyloid and tau, Alzheimer's is a circuit-based disorder. Disrupts the brain networks, and the classical features that happen early on is a decline in memory functioning. Now, we have disease-modifying therapies that have FDA approval, but what's the effectiveness of them? Okay. Well, their effectiveness is really on the pathophysiological markers, right? It's meant to slow down the disease, and it's debatable how much it might actually do that. Some estimates 6 months, maybe 9 months. We're going to find out probably next year or two what that really truly translates to as we get more longitudinal data. But it doesn't restore functions. So once a patient manifests a deficit in memory or other thinking skills, it's not restoring or regaining those functions. In fact, we don't have any real treatment that is proven to ameliorate those problems. So the question is, can we do better? With what we know about the brain, what we know about where certain cognitive skills are organized, can we develop or design an intervention that actually could serve that role? So I don't have to tell any of you here, the brain's like a supercomputer. It's made up of millions of highways and connections. When you think of episodic memory, the circuit that you all probably have come to mind is PAPE circuit, right? Well, knowing what we have with PAPE circuit, certainly the hippocampus is what's closely tied to memory, but that is a very deep structure. So the question comes, can you maybe modulate and alter that circuit through other nodes or hubs within it? So the fundamental of neuromodulation is that you could maybe deliver either electric current or magnetic pulse to certain structures or regions to either directly or indirectly modulate the circuit. Now, modulate could be make it more excitable, make it more inhibitory. What you see displayed here, actually, can you see? Yeah, you can. What you see displayed here are some early principal trials looking at motor evoked potentials after giving a session of what's called transcranial direct current stimulation. Essentially, it's delivering a weak electric current to the brain for a certain period of time, and then looking at the motor evoked potential that responds, actually using transcranial magnetic stimulation to blast the motor cortex to trigger a finger twitch. Okay, so what you see is that there are two certain approaches: a conventional TDCS, which is two big electrodes, basically 5 by 7 centimeters, and then a 4 by 1 ring configuration, which is called high definition TDCS. Okay, high definition meaning much smaller electrodes, usually about a centimeter wide, which allows a lot of flexibility because with smaller electrodes, you can put many number of electrodes on the head and scalp, just like with EEG. You can configure it any way you want in order to target certain networks. And this just shows that in the green, when the configuration and protocol is with the anode, a positive electrode over the region, which is motor cortex, you get excitatory effects. Essentially, it's lowering the threshold for those motor responses. Okay? And it's stronger for the high definition form, as you can see here. Not only is it stronger, but the effects last longer. Why is that? Well, the idea is that with the high definition form, you get more focality with where you're delivering that electric current, so you get stronger effects. When you get stronger effects, they're more likely to last longer. Underneath that is actually switching out the electrode to be what's the cathode. Okay, so it's no longer the positive anode over the motor cortex, it's the cathode. The negative is basically where it leaves the body. Okay, so electric current, you always have the positive, negative. It always flows from positive to negative. So the negative is the return or where it leaves the body. Okay, so when you flip them, you actually get an inhibitory effect. So can we leverage this then to induce neuroplasticity in patient populations to improve functioning? Some says yes, some data says no. And I'd say it's going to all depend, and I'll show you why. So when we think about Alzheimer's disease, again, circuit-based disorder, we know is a well-established pattern. Early on, the brain slows down. Those circuits slow down in Alzheimer's disease, and it just progresses the further on in the course. This sometimes can actually even show up before there is real clear amyloid or tau pathology, making it really indicate that synaptic dysfunction is one of the earliest markers of Alzheimer's disease. So knowing that these circuits are slowing down, can we make the memory circuit more excitable? Can we induce plasticity within it? Okay, this is not meant to change pathophysiology, slow down the disease process, right? That's what the disease modifying therapies are intended to do. The question is, in the face of the disease, can we improve the functioning of that network to lessen the impact of the symptoms? In that sense, it's like if you're driving down the highway, we're not adding lanes to the road. When there's damage in those roads, can we make the traffic run through more smoothly, more efficiently, so the overall flow is much improved? Okay, that's in a sense what we're thinking of in terms of this therapeutic. It's not meant to alter amyloid or tau accumulation. Okay? Now, with that being said, most treatments don't alter true pathology. Okay? If you think about any neurologic or psychiatric condition, okay, they're symptom-based treatments. So this is where this really kind of fits in as a possibility. So knowing what we know with PAPE circuit, you have hippocampus being what's most closely tied to encoding and consolidating information in a long-term memory. But that's just one node, and it's a major node, of course, but there are other connections within that. One of which is the anterior cingulate cortex. And that is a much more reachable target for neuromodulation approaches. It's still somewhat deep, but it's certainly more on the surface level and capable of being reached. And Dr. Hart's work has previously shown that delivering a high definition form of TCS shows very encouraging signals for being able to alter the neuronal firing underneath, medial prefrontal cortex aligning with the anterior cingulate cortex. So why has anyone done it? So this is a paper we published that reviewed not just neuromodulation techniques in Alzheimer's disease, but another common form of progressive neurodegenerative disease called primary progressive aphasia. Why do we pick those two? Well, those were the two that have the most research that's been done since 2007, investigating these techniques as interventions. Okay, so primary progressive aphasia was actually the first, then it was Alzheimer's disease. And, TMS, TCS, the conventional form, certainly the most frequently. You probably have heard of alternating current stimulation. That's one of the more recent approaches. Very few studies have been done, at least about a year and a half ago. It shows promise. So what we're trying to do is basically leverage TCS, utilize high definition approach, and can we improve outcomes? And what you see here on the left are the targets for all the approaches that have been published up to that date. And you'll notice that a lot of them concentrate on dorsolateral prefrontal cortex. Why is that? Well, we think of TMS. FDA approval for TMS for depression is left dorsolateral prefrontal cortex. So a lot of individuals and labs have been taking from the TMS literature and work and trying to apply it in the neurodegenerative field. The idea behind that is there's basically a functional connectivity with anterior cingulate cortex. But findings have been mixed. In terms of the prior studies, nothing really stands out for showing a solid evidence base. Yes, statistically significant findings have been observed, but they haven't really been that impactful. Are y'all familiar with the MMSE score? Yeah. Did you see a change of 1 or 2 points on an MMSE in a patient with dementia? Is that meaningful? As a clinician, I'd say no. Okay. A few days later or a couple weeks later, they're not able to tell you which floor they're on. Well, you kind of told them that first time. So that's not that impactful. It doesn't really translate to a highly relevant outcome. Not only that, but a lot of studies tend to focus on the global cognition metrics rather than specific cognitive abilities we know are impacted by these conditions. Memory being one of them, but there are other ones. Language, executive functions. Very few studies have really focused on the specific cognitive skill sets to really demonstrate efficacy. Now, with primary progressive aphasia, that was a little different because that's a language disorder. So a lot of it has focused on language, but with Alzheimer's, it really has been focused on this brief cognitive screen measure and looking at improvements, and it's been mixed, not surprisingly. As a psychologist, it suffers from ceiling effects. It's not the greatest measure to be evaluating for a change because there's not much of a window of opportunity to even observe a change. So what we have here is a display of a computational model of our protocol of HDTTS. And really this was Dr. Hart's kind of brainchild of how do we align the electrodes to best target the anterior cingulate. Okay. So this is a computational model on the right of a brain template of the average Alzheimer's patient. So essentially we took open source data of MRIs from Alzheimer's patients and downloaded it, entered it into computational modeling software, and ran many different configurations to try to identify what produces the maximal electric field distribution in our chosen target of interest, the anterior cingulate cortex. And you can see it's not truly focal, right? You know, it's not limited to just anterior cingulate cortex. Essentially, medial prefrontal, according to these models, are getting some level of pretty strong electric field distribution. Could we go more focal? We could, but the downside is when you're working with electric current, it's going to take the path of least resistance. When you're delivering it over head and scalp, it has to pass through tissue. It has to pass, or skin, that is. It has to pass through bone, okay? And then CSF. So all those, a lot of the electric currents just going to shunt off the surface. Okay, very little is actually going to make it through. With that being said, it's hard to control exactly where the electric current is going to get it to because of that. There are variations from one person to the next in terms of the level of atrophy they might have. That might actually alter some of the effects. And there's quite a bit of variability there from one individual to the next in terms of this patient population. So, you know, thinking about if we were to put all the electrodes together, truly a focal protocol, would it boost effects and outcomes? Well, we tried that. It didn't really work. And the reason we think it didn't work is because the electrodes are so close together. Majority of it was just shunting off the surface, going to the next electrode. Okay, so since too close together, they actually prohibit seeing any sort of neuromodulation effect. So having them further apart, less chance of shunting across off the surface and leaving the head without any actually penetrating through the scalp and skull. So in our first pilot trial, it was actually with patients that had mild, moderate dementia, suspected to be due to Alzheimer's disease. We actually tested two different active protocols, very, very low current, a 1 milliamp current, and then a 2 milliamp current. This was compared to sham. You know, with the sham protocol, this is not like TMS. With the sham protocol, there's actually a window, a ramp up period where participants would actually receive some level of active stimulation. It would start from 0, slowly ramp up to the current of choice, let's say 1 milliamp, over 30 seconds or a minute. And then after that period, it shuts off. So they get sensations of tingling, itching. Some actually describe it as stinging or even maybe mild burning sensations. So it gives patients the experience of the sensations, which does a really nice job of finding them to which treatment condition they're getting. Because most people after 30 to 60 seconds habituate to the sensations. So they oftentimes don't report experiencing really ongoing, even in the active treatment. So we did cognitive testing, 3 time points, baseline immediately following all 10 treatment sessions, and then we had a 2-month follow-up. Small pilot trial. As a neuropsychologist, obviously we give a detailed cognitive battery, our primary outcome of interest was verbal episodic memory as measured by the Ray Auditory Verbal Learning Test, but we also measured visual memory as well as measures of language and executive function. So because it was a small pilot trial, we really took a multi-pronged approach to how we examined those findings. Obviously, statistical significance is what you are looking for, but that's greatly impacted by sample size, which is why you can't just look at just statistical significance because you may overlook an actual effect that's quite large, simply due to the sample size itself. So we looked at effect size calculations, but we also looked at clinically meaningful change rates. Now, as a clinician, there's not a consensus on what is considered clinically meaningful. You may have heard minimum clinically important difference. That comes up a lot in science. On the cognitive side, many measures don't have a minimally clinically important difference established. So as a clinician, if I'm seeing people from one time to the next, my minimum threshold would be half the standard deviation. And the reason why is this translates to actually converting to a different performance category, such as being mildly to moderately impaired versus mildly impaired. So they get a boost into a different performance classification in terms of their test result. So our definition of what was a clinically meaningful change was either improvement or decline by 5 T-scores. Score means, that's a standardized scores. Usually these tests are adjusted for demographics, age, education, even sex. So the findings were published in Journal Prevention of Alzheimer's Disease. And here's what we saw. So on our primary outcome measure, Ray Vault total learning, which is the amount of information one is able to immediately recall after each trial for 5 learning trials. Okay. So you can basically, this is a different score or delta score. So you can see for the sham from baseline to immediate post, this is all immediate post-treatment, hovered around 0, which is not surprising. We don't see practice effects in these individuals. They're so impaired memory-wise, they don't benefit from those prior exposures. And we use actually different versions of the test anyways. But we see with the 1 milliamp and 2 milliamp active treatment, compared to sham, it was about 3 to 4 point difference. And that's T-scores. So that's pretty sizable. And the effect would be a moderate to large effect, depending on which group you looked at. Okay. Statistically, no, it doesn't show up, not surprising. But looking at the effect size is certainly a solid signal there that's encouraging. Well, what about with delayed recall? This is what you don't want to see, but it happened. Nothing, no signal whatsoever. We didn't alter the amount of information that actually got transferred into long-term memory. They weren't able to recall any more information compared to sham 30 minutes later. That's unfortunate, but that's why you do the study. When we looked at clinically meaningful response rates, okay, I'm just showing you really for the Ray Vault, the total learning and delayed recall. What you see here is that no change or improvement for the sham group, but when you look at both treatment groups, 1 milliamp or 2 milliamp, total learning, a third of the individuals that received active treatment showed a meaningful improvement. Okay, but again, that's going into a different performance category. So what does that mean? Well, response rates, if you actually look at interventional trials across different disorders, what do you think was the response rates of TMS on depression that led to FDA approval? You think it's 50%?
25.
25? A little bit lower than that, actually. Yeah, 15, 20%. So having a condition where there are no treatments available, 1 out of every 3 should be a signal for improvement in immediate recall. It's not too bad, I'd say. The question is, what does it relate to outside of the test? And we didn't have any metrics of real world functioning to compare that to say improving total learning actually translates to improvement in daily activity. That's a critical question that obviously would need to be answered. But it's encouraging to see a treatment effect from this small pilot study. So we didn't just see it with the Raybould total learning. We also did see a signal for improvement in phonemic fluency. So this is how many words can you name that begin with certain letters, usually F, A, or S. Measure of language. Someone also incorporates some of the frontal networks with executive function overlap. And what we see here is that, yeah, compared to sham actually did worse post-treatment. The 1 milliamp to 2 milliamp groups actually showed quite a bit of improvement, 7 to 8 T-score change, which is quite noticeable. For the 1 milliamp group, actually at 2 months, that persisted. Okay. And I didn't show it, but for the 1 milliamp group, 2 months for Raybould total learning, that moderate effect size actually persisted too. So it runs counter to what maybe some have suggested, that in patients where there's higher atrophy, more cerebrospinal fluid, you may need more or higher electric current in order to get to the chosen target society. Because of the effects of atrophy that plays. But one thing that's pretty clear is dosing is not linear for these techniques. 2 milliamps is not always better. Okay, it's just thought to be different. So it really is not surprising to me that we see a different effect or persistence based off of the current intensity. Now we'll have to, I think, follow this up and try to confirm if that truly is a durable effect and maintains. But can't think of these things like medications to where higher dosing or actually maybe improves outcomes. This is just where different electric current intensity may produce different effects. So when we look at phonemic fluency, meaningful response rates, so again, roughly about a third of the active treatment patients, whereas there's none for the sham. So again, that's, yeah.
Can I just ask a clarifying question? What was the montage used in this study? For the HGTCS, like what was the
actual electrodes?
Yeah.
So it was essentially almost, it's kind of a modified ring configuration. FC was the anode. FC. Surrounded by CZ, FPC, F7, and F8.
CZ.
Yep.
Perfect. Thanks.
Okay. So here's showing actually all the data for Raybould total learning across all the treatment points. And this is what I was referencing, that for that 1 milliamp, that low dose treatment group, that actual effect size actually was maintained out to 2 months, where you can see it's very flat for sham. And for the 2 milliamp group, they returned to near baseline levels. So from this study, what we're seeing is that if you had to pick a favorable stimulation, it actually looked to be the 1 milliamp current intensity. But because we didn't see delayed recall improve, the question is, again, what do we translate this to? And that's what we're hoping to do with the next study, is to try to, one, replicate this, but also identify improvement in immediate recall or language measures. Does it actually translate to real world improvement? So, it's a bummer when you don't see what you wanted to see, but that's research. The idea may be because total learning improved and delayed recall didn't, perhaps maybe the memory network is just too damaged at that stage. Once dementia sets in, maybe the circuit is just too disrupted to be modulated or improved. The other idea is that, well, maybe what we're actually hitting is more of the frontal networks, the retrieval processes involved in memory, which wouldn't be too surprising given the area of location that we had for our chosen site stimulation. So it's very well known. You can see this with Parkinson's disease, where patients will report having memory problems, but they don't have a true amnestic syndrome. They're not forgetting. What they have is an access problem. They're encoding information, they're just not able to find where it's filed away. So when you ask them what were they told earlier, you get a lot of don't know responses, or I'm having trouble, it's gone. But you start providing them some prompts and cues, it helps find where it's filed away, it helps them retrieve it. So it's possible the immediate total learning is more of a signal of improved retrieval, even though we weren't changing the forgetting. So, I'd say for an initial trial, with this being a very unique target that hasn't been explored before, 1 to 3 dementia patients having a clinically relevant response, it's not too shabby. That's pretty encouraging. We may have to change how we think about the targets, though. There may be certain targets depending on the disease stage. Maybe a language and executive function perhaps is a better target in the dementia, as opposed to the forgetting, that true amnestic delayed recall. With any interventional trial, heterogeneity of outcomes is the rule, not the exception. Only one treatment where you get 100% response rate. I can think of maybe 1 or 2. It's pretty limited. Drugs don't do it, so why should we expect it with what we're doing? Now, it may be that we are applying a one-size-fits-all approach. That is, we use same electrode configuration for every individual, knowing that there's going to be variability in their anatomy that may influence outcomes. So it's possible if we were to use a personalized approach that actually tailored it to their head and brain, perhaps maybe we'd get better outcomes. And we'll be exploring that hopefully very soon. So what about for the earliest clinical stage? All right, we've been talking about dementia. What about if we back up? The earliest clinical stage is called amnestic mild cognitive impairment. This is where people have memory decline or decline in other cognitive skills, but it's not to the level of the dementia. They're still functioning day to day, independently, still handling things on their own. They don't need any assistance. They just recognize that they need more help. So they're using maybe to-do lists or calendars more, having to compensate for those deficits, but still functioning quite well. Well, we did a very similar treatment protocol for them, but in this study, this was actually designed in collaboration with Dr. Hart. We added an EEG as an outcome. This was across all the time points, again, baseline, immediate post-treatment, all 10 sessions, and then 2 months follow-up. We had an open label phase for this study, which was, everyone wants to get the active treatment. So we built in an open label phase. So anyone getting sham could get invited back to go through active treatment. We didn't include it in the data analyses. It's purely just to provide that for participation, help with enrollment. You'll notice that we only had 2 groups for this study, 1 million and sham. We didn't have 2 million, okay? Similar test battery, almost identical with the exception of like 2 measures, which was actually meant to be more challenging for this population because they're more intent. So Brave Alt Total Learning, across the time points. Time 1 is baseline, time 2 immediate post-treatment, time 3 is 2-month follow-up. And what we see here are those average T-scores. Okay, so these are no longer different scores. These are the average T-scores across time. And what you see is immediate post-treatment, there's a nice split. The sham group, it's pretty flat. Not surprising, again, we don't see any real practice effects, right? So a nice split, that's roughly about 60 scores. However, 2-month follow-up, statistically, this was not significant. The effect size was quite large. And the clinically meaningful response rate was actually 50%. So that means 50% of the active treatment showed a clinically meaningful improvement. Now, story shifts for delayed recall. In this scenario, actually, we do see a statistically significant effect. The difference would be about 7 T-scores. And you can see that it's most noticeable immediately following all 10 treatment sessions, but bummer, it didn't persist in 2 months. It faded and was near baseline levels for the active treatment. Now, how long did it last? Was it 1 day? Was it 5 days, 10 days? Don't know. Did it last a month? Don't know. 2 months was our follow-up. We didn't have anything in between. But really interesting signal here that we're seeing forgetting actually looks like is being modulated. Whereas with dementia, we didn't see that. However, language, we didn't see anything either. Okay. So even though these were patients that had amnestic mild cognitive impairment, where language decline often occurs as well, just because of, in Alzheimer's disease, it's the most common cause of MCI. Memory is not the only thing that's impacted. Usually language is typically impacted as well. We call that multi-domain impairment. And as the disease would progress, you then get other areas of cognitive skills impacted as well. Executive functions usually coming not too far behind that. The trial was actually designed to try to enroll those that had language impairments. Our enrollment criteria was for them to have diagnosis of amnestic MCI, but they also had to demonstrate a deficit in language that would have been obtained in a clinic setting. So 1 of 3 possible measures that would have been given if they showed a deficit on any one of those, then they were eligible to. However, looking back at our data, it's clear that we did not end up with multi-domain amnestic MCIs. We mostly ended up with single domain, those that had memory impairment. Because if you look here at the actual T-scores for language, so generally we're thinking impairment 39 or below. You can see that for both groups, sham or active, are in the 40s, and some even near 50, which is the average. So that's your healthy control performance. And so many of these people were not impaired in language, which has led us to think that, because the circuit's functioning near normal for language, there's probably little chance of it actually being modulated. That maybe there's this window of opportunity. You need some damage to the network in order to be modulated, but maybe not too much. So in language functioning, the anterior cingulate cortex is a major hub for them oftentimes. So that's why we were thinking language potentially could be influenced in this population as well. For the meaningful change rates, I mentioned that, for here illustrated on the left, this is just for the Rayvault delayed recall. 50% of the active treatment, you see no one declined, but for sham, most people were stable, some performed worse. Now, why would someone perform worse? 10 days. Well, these are different forms. Okay, so there's a different basically level of difficulty, these forms for the ray vault are not equivalent. In fact, I'd say any test that says it's equivalent and it's alternate forms needs really to be tested thoroughly, because in most instances, in most populations, that probably wouldn't actually hold true. And in this case, it's not surprising to see, a different test, you see lower performance maybe in some. Which is sham in terms of the total learning. Now, some did show actually clinically meaningful improvement, about a third. That's compared to 60% of the active. So did that maybe wash out our chance of seeing an effect? Perhaps so. When we looked at just the change rates, statistically, delayed recall for the ray vault did come out in a chi-square analysis showing that that was a statistically meaningful improvement percentage. So in terms of, all right, how do we weave these together? Well, I think it's disease stage probably matters and plays a role, not too early, but not too late. And your targets may change depending on what stage it's at. Okay? It's encouraging to see improvement, delayed recall, but there may be a possible ceiling with the circuits if they're functioning normally. There may also be a possible point of no return or no chance of being modulated once the circuits become too damaged, like more advanced stages of dementia. We can't comment about how long these effects might last. And mechanism of improvement for most trials actually has remained unknown. Now, I mentioned earlier that we incorporate EEG, and I'm going to get to this very quickly. So let's say that our treatment effect is short-lived. Maybe it only lasted a couple of days. For some, that would mean, well, there's no potential for clinical translation. And I'd say, well, do you just take a medicine 2 weeks out of the month, or do you take it every day? Take it every day. So is it possible to then do something similar to where this would not be burdensome, but could be delivered long-term? And it is, yes, it is possible. There have been ways to deliver this at home, remotely supervised, where you can actually have a custom head-built cap for each individual with cutouts for electrodes. That's something that we hope to explore in the future. The question is, though, does it actually improve outcomes if you have it personalized and tailored? Theoretically, it makes sense, but scientifically, it needs to be proven. So, returning to our EEG. So this was a task you probably have all heard of before, kind of a semantic object retrieval task that Dr. Hart uses quite a bit. These participants were given 2 conditions. Basically, they either saw word pairs that, when seen together, usually trigger retrieval of a real word, like pumps and deserts camel, he uses that a lot. Or it's 2 word pairs that really don't belong to each other, so it doesn't retrieve an actual real word. Okay. Then there's the associated condition. We didn't find anything with the associated condition or not associated condition, so I'm just going to briefly mention the retrieval trial here. And if we were to see any sort of effect in terms of EEG, it should be that medial prefrontal area, right, given our configuration. So for transparency, here's the full time series of the data that Dr. Zhang analyzed. I'm going to zoom in just on this particular time series. What you see at the top is the retrieval condition. So this is when there's actual 2 word pairs that trigger retrieval of a real word. Comparing active to sham post-treatment, there was a significant difference in the theta rhythm under the area stimulation, what you see right here, right where we expect possible engagement and modulation. But it only happened in the retrieval condition, not the non-retrieval condition. That's not too surprising, right? When we think about retrieval, if it's a real word, it's engaging the circuit. When it's not a real word, it's not engaging the circuit. So it's not too unexpected seeing that difference. So the findings are encouraging that, is this possible target engagement? Maybe. Is it a plausible mechanism for treatment? Perhaps so. Theta rhythms is something that typically slows in Alzheimer's disease. So the fact that we were strengthening that, in a sense, enhancing it, means that maybe it could actually be related to the improvement in verbal memory that we saw. And Chang has done some correlation analyses examining the association of verbal episodic memory with those EEG changes. And the findings were actually quite encouraging, more so for total learning than delayed recall, but pointed to a positive direction at least. We'll obviously have to do some more research to identify if this actually represents a mechanism. Hope to pull in other neuroimaging techniques. I think you heard from my colleague, Dr. Amy Proskovec, not too long ago, incorporating MEG, actually trying to do follow-up studies, integrating that to have better resolution, to really kind of refer more to what are the effects of our protocol on neural activity. So with that being said, I'm going to open the floor to questions. Hopefully stop sharing. Looks like it did. I don't know if anyone online is they're able to pop up or raise a hand or anything like the normal Teams functions, but feel free to just chime in with any questions.
Yeah, we'll let people in the room go first and then see where we go from there.
Sure.
Thank you so much.
Right, I can
Jump things off, yeah.
start. I have a couple of questions,
Yeah.
but I'm gonna try and into two. So my first question goes to your first two studies that have looked at MCI and individuals with dementia using TCS. I know that some of the current medications used to treat Alzheimer's symptoms include NMDA antagonists and cholinesterase inhibitors. Did you control for medication use? And the reason I ask that is because I believe there's a study by, it was either Charlotte Stagg or Michael Nietzsche, that had shown that NMDA antagonists ablate the effects of TCS.
We did not, and the reason why is all these patients are taking it. So what we did instead was make it to where they were stable on whatever dose that they were getting for at least a month. Otherwise, we would have never been able to enroll anyone. I mean, those are prescribed simply with someone even reports having a memory change. So primary care is prescribed them before they even are demonstrated to have a memory impairment. So there's no way for us to limit. The second reason why I'd say also is that study did demonstrate effects, but what was it on? Motor. And we can't think of motor exactly the same as thinking and cognition. It's much more complex. So the question remains, would it truly have an effect on cognition? No one can really answer that. From our data, we did look at proportion of individuals that maybe were taking another medication, not Aricept or donepezil, but maybe Namenda. Kind of comparing, did we see any differences in responsiveness based off of that?
Yeah.
And we didn't.
Okay. That's what I was thinking. And then I guess my second question has to actually do with the kind of the studies that you had looking forward as far as using like the CAP and like personalized TDCS. I know you mentioned, I'm going to try and get this into one coherent question, but I know you mentioned there are other factors to think about as far as current flow, so i.e. skull, fat, tissue, and CSF, which can also shine electrical current. So other than like targeting the placement of the electrodes via the cap, how that might still alter current flow. So even if you're delivering a current to the same location in two different people, one might have more CSF, for instance, that might shunt the effects. Are you also titrating the dosage to see the underlying current getting to the core tissue as opposed to
Right time.
surface level? Yeah.
We have not altered the duration. Everyone's gotten the same in a trial in terms of 20 minutes.
Mhm.
We have one that's trials going on right now that should be coming to us in later this year. Being completed later this year is 30 minutes. We have not looked at the staggering, maybe timing influence, but
I was thinking more intensity. So for instance, if you have an individual that has a lot of CSF, for instance, their current flow, the intensity that they're getting to that underlying cortical tissue is going to be different than someone with nice healthy load. So I just didn't know if that was something.
That's a good point. Perhaps, doing a trial where people, if they don't show an effect, maybe get rolled into another sort of protocol could be considered, TMS, a lot of the early work did that actually for non-responders. So I think it's a good question that maybe it wasn't the right fit for them. And certainly, you could always, after the fact, if you have like a brain MRI, you can actually run the computational models for these individuals. So we can see how far off maybe with this configuration would the electric field have been for that chosen target. That's given these were pilot trials, we didn't have MRIs, but certainly I think that's something that would be valuable, is looking to see, does that explain either response or not, and enrollment into maybe something else.
Tom, just to follow up on that, I was wondering whether, in FNERS, you have the double banana. Nowadays, you have to use short channel, not just long channels. You have to, dedicate a short channel to see how the CSF is for each person, and then you take that into consideration. I was wondering if there is something similar going forward for the TTCS, where, how big the CSF could be potentially, or model it. Without having the MRI. I mean, of course, it's great if you have MRI, but for many patients, there might not be MRI.
Yeah, you're right, actually. It is restrictive a little bit for MRI, just because of metallic implants. Now, TCS, as long as it's not in the head, generally it's okay. I don't know of anything in terms of computational models or figuring out sort of, in a sense, dosing techniques without thinking about the brain anatomy. I can think of one. Open to listening to it for sure. I don't know. Certainly the computational models themselves have come a long way and are highly sophisticated, and several of them are free. You don't even have to pay for. They do just as good a job as the ones you do have to license. Saw another hand go up. Yep.
I didn't hear everything that Dr. Basakri was, but I was wondering if is there any prospect within your data to kind of try to dive deeper into individual differences? So is it those that improved in of the 50% that it worked on, are those the 30% that, for example, in example in your behavioral measures, can you find patterns among individuals that might be, maybe that was a computational. Okay.
And then how much CSF it is, and maybe it's not hitting that day. So
and exactly. And the other thing would be about where is it placed and how is the brain structures. Another, if you think about oscillations, about anything that you do with the frequency, the composition in the signals, can you find the specific frequencies for the theta?
Yep.
Can you look at the periodic activity of those individuals? There's a lot of different ways that might be really meaningful. You need more data.
For sure,
and all that, but you have a lot of very good measures to try to kind of use in characterizing those individuals. So
with our MCI trial, having the EEG data, certainly something I like to dive deeper in, is looking at baseline. Are there any signatures that could predict or classify response? For sure. And I'm just waiting for Shang to have some time available to analyze those, or John. We all know how busy he is. But you're right. I think there could be something there that could actually help maybe inform selection criteria. Who actually should be and most likely to benefit. Great point.
But, given that you seem to identify effects in multiple domains of cognitive batteries, right? To some extent, and then the verbal past, but not in others, attention, executive function. I guess I'm wondering, could you offer a parsimonious explanation as to why you're seeing effects in those different domains that presumably are supported by very distinct sets of circuits?
The chosen skills of interest and basically the others, that potentially could change or be influenced by where we're stimulating, right? You think working memory possibly, or executive functioning. Why do we not see those in a sense change? It's hard to say. With our MCI trial, again, they just had memory impairment, really. They didn't have impairments in other areas. Our dementia population, obviously across the board, they were impaired. The problem was our measures of executive functioning, our patients were so impaired. General administration, they actually discontinued the task, and no score was really derived to even analyze those. And I had a student who was actually at UTD at the time that did this. They actually went and hand scored like trial making tests, created an efficiency index, looking to see how efficient were they before they had to discontinue due to time. They're working on the paper right now for it, but what they did show was actually a signal for improved efficiency in the active treatment. But looking at just the standardized scores, we couldn't actually evaluate those because you don't get any usable data in a sense from how they're typically scored.
So given that additional data point too, do you think it's non-specific? Do you think there's a general?
It's a good question. I think it could be affecting executive function, at least in the dementia population, more so than anything else. That's playing out with phonemic fluency, immediate total learning, maybe this other measure. We have to be, I think, more crafty with how we're measuring executive functioning in dementia patients, just because the traditional measures, don't provide the data that I think really allows for analysis of that. So I think if I had to select, rather than say it's more generalized, I'd say it's probably more executive in the patients with dementia. Now, why did we not see it with MCI group? Well, because the circuits were functioning pretty normal. That's my hypothesis, but obviously we need to test it.
So it depends on whether in Trail C or B you actually used the cutoff that they say you have to use it, or you kept on doing it. And we're running a
When they go
trial.
when they go 5 minutes.
Yes, we are actually allowing the entire time to run out, and some person took 17 minutes, and that's because otherwise you can't see pre-post change. And so if you're using cutoff, then 5 minutes and above cutoff, 5 minutes and above cutoff. You have no idea whether there is a change or not. You're looking at floor effect and another floor effect. So that anything with reaction time, it's ending up to be that. And so RBLT is turning out to be the most easiest one to administer. At least people are saying wipe instead of white. Some responses coming up.
Yeah, it's tricky choosing your outcome measures and also not burdening the patients. Well, they don't like the testing. They dread it because they know what's coming. So try to collect the information you can and not overly burden, where they're just going to withdraw or something. Thank you very much.